At its very core, drug science must remain independent. This means we don't accept sponsorships. It's with the support of the drug science community we're able to do this and make the podcast in the first place. If you're able to become a drug science community member and support the show, you too will be supporting the dissemination of evidence-based drug policies. Without you, none of this would be possible. For anybody interested, there's a link in the show notes. Thank you. Hello and welcome to the Drug Science Podcast with me, David Nutt. Here we're bringing together experts and activists for a rational, honest and informed conversation about drugs.
Hello and welcome to the Drug Science Podcast with me, Jo Neal, hosting this one for the first time. So I'm hoping that you, our listeners, won't be too disappointed to not have David Nutt here today. But luckily for me and for you listeners, I have a brilliant guest with me and we have much to discuss. So we'll be talking about psychedelic-assisted therapy, psychiatry, what it's like to work in the NHS as a consultant psychiatrist, music, and many related topics, I am sure. And that guest is Dr. Graham Campbell. And although we have worked together on an academic project, we've not actually met properly in person until today. So I am so excited to have Graham here today. You're in for a real treat, everybody. Graham is a psychiatrist, and he has a special interest in psychoanalysis, which I guess is maybe not typical for a psychiatrist. I could be wrong. In consciousness and in music, and he makes his own music. So he worked in the NHS for a number of years, but then he jumped ship and he now works in psychedelic-assisted therapy because that has not come into the NHS yet. And he is now the director of clinical psychiatry at Small Pharma. Small Pharma is a pharmaceutical company developing a psychedelic, DMT, dimethyltryptamine, for psychiatric disorders. So a very warm welcome to you, Graham.
Thank you so much, Jo. It's so great to be invited to come on the podcast and talk. Lots to talk about.
Lots to talk about. It's such a treat for the listeners to have you here. So I thought we'd start at the beginning of your career. So your early career, your decision to do medicine, to study medicine to start with, because that's so difficult. Then to go into psychiatry and then to work on psychedelic medicine. So how did you sort of come to where you are?
That's a big question.
It's a lot.
So I think I've just always been a really curious person. I was a really curious kid. I got really interested in science in middle school, so it would have been just before secondary school for most people. But yeah, really interested in science. I think I wanted to be a doctor when I was 12, from the age of 12, and then I think when I was 14, I wanted to be a psychologist. I think I'd given up on the idea of becoming a doctor. And then I realized after a little bit of time, there's a thing called a psychiatrist. By that time, I suppose I was always curious about my own mind, about dreams. Maybe from about the age of 12, I was kind of thinking about dreams and, what they mean. Why do we dream? What is sleep? What's all this weird stuff that my mind does at nighttime?
Oh, did you have very vivid dreams as a child?
I remember wanting to eat lots of cheese to try and make my dreams more vivid. But yeah, I think I had lots of dreams, and there was a period of my teenage years where I was kind of keeping record of my dreams and doing a dream diary. And we did an exercise at school where we had to do diaries, and mine was a dream diary, and we put it to music and made a recording. But I suppose, I've always had that curiosity, that interest in science, that curiosity around people. And probably my parents encouraged me a little bit, I'd say fairly gently, down that kind of path. And I remember wanting to also do creative stuff as well. I wanted to do art in school, but I sort of veered towards the academic subjects. And then, I had a break after my A-levels, but I actually literally had a break. I had a road accident and I had a serious leg injury.
Ooh.
Yeah, that was quite a big deal, but it gave me a lot of experience of being a patient.
Which most doctors don't have until later in life, really. I guess.
I think that's probably true. Yeah. I mean, I've met a lot of people who've had similar kind of experiences of being on the receiving end, either through, being a carer for family members or having illnesses themselves. But yeah, I think it was a really powerful experience and really showed me quite a lot about what good care meant. It was a real difficult experience at the time, but being on the receiving end, experiencing the kind of real human side of care, I think was so valuable. So I think that informed, it set me back a year. I had to reapply to university, but that certainly informed, my practice and really encouraged me to pursue it more.
Yeah. And where did the psychoanalysis come from then?
Yeah, that's a good question. I remember trying to read Freud when I was about 14, 15, not understanding very much of it at all. I just found it so dense and complicated. And I think again, it was, this idea of the unconscious mind, where where ideas come from, where dreams come from, where this idea of the sort of symbolic, I think through art as well. I think that, I was very interested in visual art, and in my late teenage years, following the Turner Prize and the work of Salvador Dali and René Magritte and the surrealist painters. So that sort of infused into that interest about the unconscious. So yeah, didn't understand it when I was in my teenage years at all, but started again trying to read a bit more about it in my first year of medical school. And that was actually alongside reading about psychedelics as well.
So early stage, you were interested in psychedelics.
Yeah, absolutely. Yeah. Some of that I think was from in my year out when I was recovering from my road accident and my leg injury. I did a psychology A-level, like an additional A-level during that time to sort of keep me occupied. And in that, there was talk of psychedelics very briefly as a sort of model for psychosis that used in that sort of way to help people understand. And that was about as far as the conversation went in A-level psychology. But then, you'd see stuff on telly about the 60s and people having psychedelic experiences at music festivals. And for me, I remember this curiosity of thinking, well, that doesn't really add up. If it was just a model for psychosis, but people were using it and talking about it and, it was influencing music and, creativity and culture in these rich ways, then how do I make sense of this?
And Graham, I remember you saying you wanted to be in the 60s. You wished you'd been around in the 60s.
Yeah, I do remember. I must have been about 17, I think. And I do remember one particular day, and I think it was one particular TV program or something that really triggered this kind of, I don't know, sadness that I lived in the 90s, and I was, that was my formative decade, and what happened to the 60s, and where did all that idealism go? And I remember I got really sad about not living in the 60s. I think it was a fleeting thing. I don't still harbor that fantasy. I'm sure the 60s have been caricatured and hyped as well. It wasn't all, hippies and love, but yeah, I remember having that sort of curiosity about the 60s and the music from the 60s and yeah, that whole sort of scene.
Yeah. So what was it like working in the NHS as a consultant in psychiatry? So you were working in an inpatient unit, I think?
Yes, yeah. So I'd worked in an inpatient unit as a trainee, throughout my training, having graduated. So I'd worked around Sussex mainly, actually. And so I'd worked in various psychiatric hospitals in Sussex Partnership NHS Trust throughout Sussex. And then from 2011, that's when I started working at Millview Hospital in Brighton and Hove. And initially as a trainee, and then as a locum psychiatrist at the end of my training. So I worked in the intensive care ward. I worked on the female, adult, general, acute ward for about 7 months as a locum consultant psychiatrist. And then worked on the male ward for about 8 years, actually, from 2012 until 2020.
I think our listeners would probably want to know a bit more about how it works in an inpatient unit. So these are people with acute mental illness.
Yeah, so my responsibility was, as the senior psychiatrist in the team, looking after 20 men in an inpatient ward probably about 2/3 of the people that were in the hospital or on our ward were detained under the Mental Health Act. It really fluctuated. Obviously we tried to make it as least restrictive as possible, and that's a big part of the Mental Health Act, is the effort to try and use less restriction and work with people in a more collaborative way. But due to the nature of the people who would be admitted to hospital, and really that's usually a last resort, and often for the Mental Health Act you have to demonstrate that you've really tried to support somebody in the community, in a much less restrictive way, try and help people in their homes and outside of hospital. But the people who are usually in quite a serious state of mental health crisis are the people who get admitted to hospital and come under our care. And that's also usually people who are really struggling with either looking after themselves because of their mental illness, or who present a risk to themselves or other people. And so, yeah, it's I wouldn't say it's a last resort, but it's a resource that is used at, after lots of other things have failed. And our effort is to really try and help people's mental health stabilize to the extent that they can regain control, regain that autonomy to start to be, well, our aim is always to discharge people from hospital as safely as possible and help them be able to pick up, their recovery with community support out of hospital. So it's usually quite sort of high intensity work, really, really close teamwork. And, I was fortunate enough to work with, such a great team on Regency Ward at Millview Hospital, and the team at Millview Hospital and, Brighton and Hove Acute Mental Health Services were a great team to work with. And so, it wasn't always an enjoyable job. It was
a hard job, Graham, I would say.
Yeah, very hard, very challenging work, a lot to think about, a lot to hold in the balance all the time. But, so satisfying to see people be able to regain that control and that sense of autonomy and that ownership and, of their mental health recovery. So that was
the goal. So, Graham, are these the kind of people who would benefit, do you think, from psychedelic-assisted therapy? The sort of severely depressed and maybe traumatized?
Yeah, so I'd thought about this quite a lot, because in the last couple of years, the last 2 or 3 years of that job, I'd already started working with Imperial College as much as I could, as much as my day job would allow. I was a sort of assistant psychedelic guide at Imperial, which we'll probably come on to talk about a little bit more. But during that time, I was kind of in this mixed role of learning more about psychedelic therapy and learning more about therapy and the application of therapy, psychotherapy, whilst at the same time working in this acute setting where, with the best will in the world, a lot of the intervention was medicine, was kind of, antipsychotic medicine, antidepressants. And so, I spent a good few years really thinking about this and trying to, integrate, I would say, these different approaches. And actually, what helped me really get into the psychedelic field was, I remember a patient I worked with who it appeared initially like none of the standard treatments were really working. When he was admitted, he was profoundly depressed. There was a very high level of risk to himself from his depression. His life was in danger really from it. And I was presented with a story that no medicine was helping. And so that's what led me down the path of actually in the Maudsley treatment guidelines, looking at what additional treatments might be useful. And actually there was ketamine. But I think at that time it was before, some of the Spravato trials, and the evidence was saying it looked really promising for ketamine, but essentially it said good luck trying to access that treatment for some. Yeah. And it was something I really explored and looked into and spoke to our pharmacy departments. And, there were real logistical challenges about it. And it was still very kind of off-piste at the time and off license, I think, at that time. But that really opened my eyes. Most of the people that I worked with in the hospital had psychotic illnesses like schizophrenia, schizoaffective disorder, or bipolar affective disorder with psychosis. And that was usually the reason why they were admitted, because there was that sort of difficulty with reality often, and a real loss of, like I mentioned, loss of control. And so the vast majority of people I worked with in the hospital, I was really clear that wouldn't likely benefit from psychedelic therapy and would be contraindicated in the trials as well. But there were people who, and every psychiatrist has had, I think, this experience of working with people who seem incredibly stuck, through depression, through anxiety, and sometimes through, experiences of trauma as well. But, the depression left some people feeling incredibly stuck. And I remember occasionally thinking throughout my training, actually, that if only there was some way to really help people become really unstuck, to find a different approach, to catalyze therapy in some way, that might really help some people, in the right circumstance, with the right support, the right approach. So, yeah, and thinking about that patient I was mentioning with the potential ketamine therapy, I was thinking, well, when most of our conventional treatments have failed, maybe we need other options. Maybe we need to think differently. Maybe we need to find other approaches.
Do you know, did that person ever get ketamine when it became more available?
So I don't know, actually. I mean, that's one of the downsides of working in a service that is quite divided between community and inpatient. My work was dedicated for the inpatient work, so I sometimes got a sense of how people were doing in the community, but I wasn't able to really follow them very consistently. So I don't know. I mean, one thing I will say is that, I'm certainly not somebody who's anti-psychiatry or anti-psychiatric treatments. There's a whole lot of nuanced discussion about the pros and cons and the benefits of psychiatry and potentially overreach and the harms. But medicines, I mean, we found a treatment plan that actually worked for him, and the medicines do work in lots of cases too. So thankfully, he was helped without ketamine and without resorting to other treatments.
So a good, happy ending. So, Graham, then you start to work at Imperial. So you're also, doing this alongside the psychiatry work. So that's a lot on top. And how was that experience then, working on the Psychedelik 2 trial, I think it was?
Yeah, it seems like such a long time ago now, I have to say. It seems like... so essentially, I'd consider that to be an apprenticeship of sorts. I was an assistant guide, so I was always there with one of the core team. So that's Rosalind Watts, Michelle Baker-Jones, Roberta Murphy, Johnny Martell, Ashley Bynum-Murphy. So that it was a really special team to work with, a team who, everyone was really quite new to the field, but everyone was incredibly caring, incredibly compassionate. A lot of thought going into what we were all doing and how we were supporting people. A lot of excellent support from Tim Reed, who was our psychotherapy supervisor. So, I mean, I supported a small number of participants in that trial because there was a core team and I was there as a sort of backup, additional support. And I had to clear it with some days off from my day job. So I had to kind of, I couldn't do as much as I wanted. But, following people through that trial, following the supervision, the psychotherapy supervision process, it was like a regular pilgrimage from Brighton to London on a monthly basis to really go into quite a bit of depth and talk about, the whole process of psychedelic therapy and what was happening and how it was for the team and how it was for the participants. It was such an education, such a different way of thinking about depression, this condition that I'd been working with whenever I say traditionally, I think it sometimes sounds like, traditional psychiatry in a traditionally psychiatric way. So it was a real, learning experience and really well-supported team.
That must have been just a brilliant, and the results are excellent.
Yeah, that trial, it's interesting with that trial, because I think the results were excellent. I know they had the sort of primary outcome score, which was the QIDS, which was one of the only measures, as far as I recall, that didn't separate statistically from the escitalopram. So I should say that it was a comparison trial. Actually, it was originally designed to be more of an imaging trial, but there was this sort of this outcome measure of depression, of course. And so, yeah, they were comparing it with escitalopram, and escitalopram is a good antidepressant. It's an antidepressant that a lot of psychiatrists, or some of the research was suggesting, is one of the more effective, one of the better tolerated, one of the more effective antidepressants. And so, to demonstrate that psilocybin, 2 doses of psilocybin with the therapy, and that's the important part as well, that was as effective as a leading SSRI antidepressant. I think, that's a really important step. And then there were a lot of secondary outcome measures that also showed, that there was a statistically significant separation and some benefit. Of course, the primary outcome measure has to be focused on, but I think it was a really, really important result.
I mean, we could argue, Graham, about clinical trials, those randomized controlled trials, being a bit too restrictive in having the primary outcome measure, because clearly they did, as you say, they did separate. Psilocybin did show benefits in the secondary outcome measures, quality of life, and kind of really important indicators.
Yeah, absolutely. And I think there was also, some differences in how well the treatments were tolerated as well. There's a lot of talk at the moment around the challenges with SSRIs, the side effects, which are challenging, and coming off SSRIs can be challenging for some people as well, and really sort of complicated. But yeah, I think it was a really important trial, and it's really important as well that escitalopram showed, such good results too, because the contemporary narrative is that antidepressants don't work, and maybe it is a much bigger discussion than we have time for, but there is evidence to show that they do work. They don't work for everybody, and maybe they're overprescribed for a lot of people. And maybe, I might go off on a tangent now, but maybe there is a lot that we as a society can learn about the medicalization of human emotion and different ways of managing that. But people who had the escitalopram in the trial, they didn't necessarily have psychedelic therapy, because that in itself would have been less possible, because there wasn't a psychedelic experience to work with. But there was still care, and support. And, I think that's often, perhaps that's underplayed in traditional psychiatry and traditional health services, that actually the care can make a huge difference in the treatments we give as well.
I would say absolutely. And we need more funding, don't we? So experts like yourself have got more time for, therapy and talking and listening to people, I get.
Yeah. Time is, I think, yeah. When you think about GPs do an incredible job under really challenging circumstances, and in the time that they have available, it's absolutely remarkable. I take my hats off to GP colleagues, because, they have to achieve so much in such a limited amount of time. And in mental health services, we have more time. Sometimes, maybe other specialties think we sit around drinking tea, just chatting all day, but which isn't the case, I will say. It's you're lucky if you get a cup of tea. But, we have more time to talk. But even still, there's a structural pressure. There's the need to do a lot with increasingly little. And, it's some of that which I think causes so much of the challenge in mental health services and in health services in general.
Absolutely. Yeah. And that really has to change. So that kind of brings me on to bringing psychedelic-assisted therapy into the NHS. And people like yourself will be at the forefront of delivering that when it, becomes available. And clearly we badly need this. As you say, not everyone will respond to the same medication, and not everyone will respond to psychedelic-assisted therapy who, qualifies. But we badly need alternative approaches. And yes, how do you see that working within the sort of NHS structure?
Yeah, that is a really huge question, and one that I am glad you asked, because it's something, we've already started to think about. A colleague of mine in IPT, which is the Institute for Psychedelic Therapy, and she was one of the co-authors on the paper that we submitted for the Frontiers in Psychiatry journal a year or two ago now.
For the listeners, Graham, we'll put all this in the show notes so people can access them and the original paper. Yes, which I looked at today. It's great. It's really interesting.
Absolutely. And that paper was about the readiness of psychiatrists to implement psychedelic therapy, which is kind of very much focusing on the opinion of psychiatrists in Sussex Partnership NHS Trust. That's where the people were surveyed. So Catherine Forster and I are already we're just having conversations about it. And it's a huge question. I mean, I think ultimately, partly what led me down this path towards psychedelic-assisted therapy was, apart from my long-standing interest, I started reading in my first year of university about psychedelics and psychoanalysis, so from the very beginning of my interest, there was this kind of literature that was kind of suggesting that these drugs, which have been vilified for years, may actually help, some people, and, may actually help with therapy, with some insight, with something to, reflect on with a different perspective, that there may be some benefit. And so that curiosity led me in 2017, after a Royal College of Psychiatrists conference, to start to get involved in this area. So it was actually the philosophy special interest group of the Royal College that put on a conference in October 17.
Well, that's interesting for the psychiatrists listening, because you're all members of the Royal College, aren't you?
Yeah, absolutely. So there was this conference that really went into, I'm aware I'm going around your question, but there's a conference that was really about the sort of ethics of psychedelic research, but a lot of people, who were kind of in the field, certainly people from Imperial and Johns Hopkins, were there talking about their research, and then there was some more historical talks and sort of and other academic talks and talks around ethics. It was just a fascinating conference, and it really triggered my interest and was a way of me making contact with the Imperial College team, really kind of spurred my interest. So my curiosity around it has always it's been this question: can it work? Does it work? Is it something that works or could work well enough to be scalable, to actually be implementable in the NHS? I mean, I'm a huge advocate for the NHS, for people being able to have access to healthcare, free, paid for by taxes, and that's something I really believe in, is the accessibility. But there's still that question, and the question still exists, is this going to be a treatment that is sufficiently effective, that's safe enough, that is scalable? And so I think, that's really why I'm doing this. That's really why I'm involved. I certainly want to see it for myself. I have a lot of hope, of course. Otherwise, again, I probably wouldn't be in this position and having left a job that I loved.
Yes, that was a big move to leave the NHS psychiatry. Brave move.
Yeah.
But a great move.
Yeah, definitely a move that I haven't really regretted. I think it's been, the right move in lots of ways. But yeah, it's definitely not one that I was rushing to make before the opportunity came up, having worked in Silodept 2 escitalopram trial, when the opportunity to work in this trial came up. So I think, part of my role is to have a bit of equipoise, to have a bit of balance. I think I'll say this, that the last thing, the mental health population, people with mental health challenges, the last thing they need is another treatment that doesn't work, and so I think we really, really have to look at this. And the best lens we have at the moment seems to be the randomized controlled trial, for all its, like you mentioned, the sort of the challenges of that, and the challenges of incorporating psychedelic therapy or any psychotherapy into a randomized controlled trial. It is the best lens we have. And so, yeah. And I think this was actually something that was borne out in the surveys and the focus groups in the paper that we wrote. And I have to give, the credit to Lisa Page and Ahmad Rayman, Habib Syed and Catherine Forster for that paper, really. I contributed a little with some oversight and guidance, but, they put in all the legwork, and it was sponsored by Sussex Partnership NHS Trust. I'll have to, think it's important to say that. But, one of the things they found was that perhaps more so than the US, this paper showed that psychiatrists in the UK, psychiatrists that were surveyed in the Sussex Partnership Trust, were very interested and actually quite open to consider the possibility of this new way of working, this new treatment approach, the possibilities that come with it. But certainly there was a need for more training, more sort of understanding around it. There was also uncertainty, and I think quite rightly people need to see the evidence. So that's something.
Graham, do you see it? It probably should come into the curriculum for medical schools and then into training, arranged by organizations such as the Royal College.
Well, I think so, absolutely. I mean, I think at the very least, I remember doing a lot of training around journal clubs, critical appraisal of scientific research, medical, clinical trials, and all of this stuff. And it can be a very dry subject in medical training. A lot of people, for all, evidence-based medicine is one of the cornerstones of what we do, but still reading papers and really kind of reading them deeply to kind of understand what's going on is a challenging thing, and it's not for everyone, even in medical training. So I remember getting quite into that. And I think, there's so much to discuss around psychedelic assisted therapy. There's so much to know and to learn for everybody in the field. And through this clinical trial process, I think it really should be introduced into the training, because I think it's also, super interesting to be able to follow this kind of process as it's happening.
There are a lot of clinical trials happening at the moment, aren't there?
Absolutely. Yeah. For a whole range of indications. And psychedelic assisted therapy is potentially pan-diagnostic in lots of ways. There's a lot has been said about the fact that, there's been criticism of, it's been tried for all these different conditions, but, it's been tried because there is a thought that there are similarities in, between different conditions, and perhaps to some degree, and, it's not just psychedelic academics or clinical trialists are saying this, but I know in America, I think it's the National Institute for Mental Health, I believe, has also said a similar thing, that, we could benefit from different ways of looking at the way we categorize, mental health, mental illness. And so there's a whole range of indications, a whole range of different therapeutic approaches and different drugs, medicines that are being tested. It's an explosion, really. It's hard to keep up with.
It is. There are more clinical trials every time I look. It is hard to keep up. And different,
Absolutely.
Different psychedelics. And so that sort of brings me on to your work now with small pharma. So, having worked with psilocybin, now working on DMT, which is similar mechanism of action, but quite different.
It is quite different. Yeah, there are similarities and there are differences. So, DMT just says a few basics, really. I suppose it's one of the active ingredients of ayahuasca from South America. In ayahuasca, there's the monoamine oxidase inhibitor in the vine, and that allows it to be an orally active decoction, liquid. And that leads to a psychedelic experience that's longer than if you were to take DMT by another route, a sort of non-oral route, whether that's inhaling the vapor or, as Rick Strassman did in the 1990s, an intravenous injection. And the duration, I understand it to be a little bit more like psilocybin, the actual duration of the experience. And I think structurally, DMT and psilocybin are incredibly similar as well. And some people have said that if you had a sufficiently high enough dose of psilocybin, more than most people dare to take, then the experience might be a little bit more like a DMT experience, but much longer.
Oh, that's interesting. Very interesting.
Yeah.
And you mentioned about DMT, or a school of thought that DMT is a neurotransmitter.
Yeah, there has been some research. I think the research is, like all scientific research, needs to be kind of further explored. And I think, some of it might be an indirect evidence from the presence of two enzymes in the brain in a particular place, more than being able to measure the concentration of DMT in certain areas. That's my understanding. But the people have raised the possibility that DMT could be a neurotransmitter in similar concentrations to serotonin or to dopamine. But again, I think that needs a lot more evidence. I mean, there is a question that because DMT exists in the body, it's thought to exist in our bodies, even potentially in our lungs and our sort of peripheral tissues, and it exists across the animal and plant kingdom in very sort of naturally. What might it be there for? Is it simply a metabolic byproduct, or is there a purpose to it? And those are big questions that I think we have to think about and explore and have some skepticism around, certainly in the enthusiastic psychedelic space. But yeah, I often think of DMT as a little bit like a psilocybin experience. But if you were to take the full psilocybin experience and squeeze it into an eighth of the duration, whilst retaining, the intensity of the experience, or, it's often depending on dosage, it's often a more immersive and, sometimes can be described as a, much more intense experience than psilocybin. But, what we hope is that some of the benefit that's been seen in depression, with psilocybin is maintained, or is kind of preserved in these DMT experiences when supported in a safe setting with psychotherapy. And I think that's the really important thing to emphasize.
So do you have a sense that different psychedelics will work for certain patient groups? DMT might work for certain people with severe depression, certain types of people, and psilocybin might work for other types of people with severe depression, depending on where the depressions come from. I know you've done some work on inflammation and depression, and that, of course, is a very hot topic. Lots of work going on at that, the relationship between brain inflammation, depression, and schizophrenia. Well, I guess I wonder about that, different patient groups.
Yeah, it might be still too early to really say. I'm a huge believer let's imagine that all the clinical trials show positive enough results to take it through to being an approved treatment. And if we had the option of DMT-assisted psychotherapy versus psilocybin-assisted psychotherapy, then, my hope is that there could be a degree of choice. There could be, there's still exploration around mode of administration. So whether it's something that can be given, there's a possibility, potentially of an oral administration at some stage, possibly, but whether it can be given intramuscularly or intravenously, those things need to still be explored. But as for the experience itself, there may be some people who would prefer a shorter experience, something that is quicker. And if you think about the services that need to provide this support, there is a benefit in potentially, from a service perspective, in having a shorter acting psychedelic, because there's less time needed, less human resource needed to support somebody through the actual dosing phase. So that is an argument that's kind of being made in favor of short acting psychedelics, but that's a little bit more from like a service perspective. And so much of it still needs to be explored. The therapy component still needs to be explored, and we need to look into that to ensure that we have the safest and the most effective psychotherapy for these treatments as well.
And maybe tailored towards the particular person. Maybe the therapy might be slightly different.
Yeah, absolutely. And I think and a big part of the psychotherapy model that we use, which was developed at Imperial by Rosalind Watts, the ACE model, which is all about acceptance and connection and embodiment, it's very much a patient-led or patient-directed, patient-centered therapy process. So instead of it being something that's systematized or very structured that we apply to people, it's very much about working in a very collaborative way, around that person's experience and around their needs, in a flexible sort of co-created way. So I think it is likely too early to be able to make some of those distinctions, and I think that's one of that. We are still early in the research, despite it feeling like it's been around for years now. So.
Yeah, for us, because you're working in it and I've been following it. So let's talk about music, Graham, for a couple of minutes. I know you make your own music, so I'm going to plug your music here. So you work as Joseph Hecht, is that right?
Work might be too strong a word. Certainly play as Joseph Hecht. So yeah, I try. I mean, it's a funny one to talk about my music because mostly it's something I've always wanted to do, to be honest. I got into electronic music in my late teens. It was an eye opener for me, and for over 20 years, I've on and off tried to produce some, to try and make it. I've always had that passion. And maybe about 4 or 5 years ago, I kind of came to this realization that it was, I mean, there's so many things that get in the way of creative pursuits, with work and family get in the way, but, make it hard to kind of have the time to really immerse yourself in it. And about 5 years ago, I just thought, what do I really want to do with my life as well as all that I am doing? And yeah, getting into electronic music and making it was the thing. So I invested in some decent gear. I try and make music with machines and less with computers. We all spend so much time looking at screens that I didn't want to have a hobby that just was sat in front of a laptop. So I use samplers, drum machines, synthesizers to all kind of connected through MIDI to try and produce music as much as I can in that way. And it's just, I'm still in a process of learning, gradually making stuff that sounds a bit better to me. Not to say that it sounds better to everyone else, but things are sort of come together.
So I highly recommend our listeners to have a listen to some of Graham's music. And I know you were influenced by Boards of Canada, Autechre, and you've also talked about Jeff Wayne's War of the Worlds. Listening to that as a child, I think.
Oh my goodness. Yeah, absolutely. I mean, that probably gave me bad dreams as a kid, and that's probably where it's all linked together. But yeah, Jeff Wayne's War of the Worlds. I mean, we used to have that played to us in the car on family holidays from, I must have been really young. And it's a really spooky, I don't know if you've heard it.
Oh, I do. Yes, my husband's very into music. We've hundreds of albums in the house, thousands. And we were listening to that the other day, funny enough.
Oh, amazing. Yeah, I mean, if people haven't heard it, I mean, it's well worth listening to. It's like it's a rock opera, would you say? Is it
Yeah,
like a rock opera, loads of synths in there, lots of sound design. It's based around H.G. Wells's book, War of the Worlds. Yeah, it's incredible. It's musically incredible. And I think there's some sound design in that I hear occasionally in the music I've listened to, which is primarily, I was hugely inspired by Warp Records music in the late 90s, early 2000s. Warp Records artists like Autechre, Aphex Twin, Boards of Canada. And I think, they have often the same kind of eerie spookiness to their music, and the sound design is incredible. But yeah, there's definitely, I'm sure there's a link between War of the Worlds, being semi-traumatized as a child, listening to that in the car on a dark, road trip. Yeah, really, really inspired me. So it's kind of led me towards this kind of slightly darker music. Yeah, which resonates.
Yeah, it's great stuff. But music within the psychedelic experience. So I have heard people say how critical that aspect of the whole experience is.
Yeah, absolutely. So as Mendel Kaelen and Bruno Garibaldi, I think, wrote a paper, must have been, I'm thinking maybe 2017, 18, maybe, about the importance of music on a psychedelic journey. And I think that's where I think it probably does need to be tailored to the type of experience that people are having. It needs to be thought about incredibly carefully. It has the power to evoke strong emotion, and to be, it is guided in that way that it can really evoke a strong emotion, but also, it's so different for different people. Obviously, the subjectivity in listening to music is so important, but within a psychedelic playlist, you tend to have a range of non-verbal, sort of non-lyrical music that can be profoundly moving within that sort of heightened, altered state experience. And so there are some advocates of no music, of silence, or of more natural sounds as well. But, I think a lot of thought has to go into it. And with Small Pharma, with our trials with DMT, we worked with Max Cooper, who is a well-known electronic music artist, for him to sort of help us by mixing a playlist that we could use, for the DMT experience. And yeah, that was so helpful, and took a lot of work to kind of think about, to refine it as well, even after we'd started, to really think about, what it was actually doing for people, how supportive it was, how helpful it was, getting feedback from people. So yeah, huge thing to think about.
So the playlist is kind of set, same for everybody, is it?
Yeah. And I think, when in the Siladept 2 trial at Imperial, that was the same as well, that there was a set playlist. I know there was, near the end of the playlist, there was a little more flexibility. Sometimes people could choose a particular track, but I think also, for clinical trials, you have to have a degree of consistency in the setting and as many of the other factors around as you can. And so that being a really important factor, we needed to have a degree of consistency. And DMT being an experience that in our trials lasts between 25 and 30 minutes, there's less room for bringing in and bringing in other music. So yeah, it became like that, really.
Mostly it's acceptable for people, or they like it.
Yeah, I think, again, everybody has their own response to it. I think in general, it's been a positive addition. It's something that's supported the experience. Sometimes people actually have said that, they're not so aware of the music. And then, you have to ask the question, is it something that's working on a more unconscious level, or is it something that, that's supporting in that way as part of the environment for the psychedelic experience? But generally, it's been really well tolerated. I mean, in the phase 1 trial, like the DMT experience itself, we've found nobody in the trial who regretted having that experience, in the supported way that we did it at Hammersmith Medicine's research. So yeah, it's been a huge part of what we do, is thinking really carefully about music.
And if you think about how Indigenous people, who of course have used psychedelic for thousands of years, I guess the shaman does chanting and singing.
Absolutely. I mean, I think that I'm trying to think of the author. There's a Anthony Storr is a quite well-known psychoanalyst, psychotherapist, and he wrote a book about music and the mind. And I think one of the aspects in that book was just, I mean, there's been a theory, and I don't know how well tested it was, but it was suggested that, as human beings, that we actually learned to sing before we could actually talk, or even dance before we could actually walk. And, whether that's played out, whether that's sort of tested theory, I don't know, but it's an interesting one. And I think really goes to the heart of how important music has been for communities and for our societies, and, maybe around healing, but also around, communing and group cohesion, and, and just the need for it that we have. I think sometimes it's one of those basic needs that so many people have, that's so obvious that we lose sight of how important it is. That's my take.
Yeah, I'm actually surrounded by music because of husband and all the music, and he's in a band, and like you, makes music. But yeah, I just cannot imagine there not being a lot of music around. It's so important.
It's so important. And people use music like medicine. I've heard it. And for me, it's a little bit like that. I don't go many days without listening to some music, if any. Oh, well, there must be some. But on those days, either I realize I need to, or maybe I'm a bit depressed, maybe I'm a bit down, maybe it's, it's a reflection of that. But actually, I think it's like seeing the wood for the trees, or the water to a fish. It's
Yeah,
something that we often need really profoundly.
I think so. And, the mind is just too busy sometimes, and it just kind of calms it down and calms that down, those sort of the multitude of thoughts, and takes you out of that in a really good way.
Absolutely.
So that's great. So, Graham, we've really We've covered a lot of ground and time has just rushed by. So just in the last few minutes or so, I just want to ask you about the other work you're doing for psychedelic medicine. So the harm reduction, the integration work, your work with mind.
Yeah, absolutely. So, I mean, I'll just say also that my work is changing a little bit as well. So I'm going to be continuing with the DMT trials. So we're coming to the end of the phase 2A trial. So it's something I think we talked about before. It's something I can't really talk about, but until the results are released officially. And then we're moving on to phase 1 trial, and then there'll be another phase 2B trial sort of on the horizon as well, if all is going well. But yeah, I thought it'd be good to mention because so my official title has been the Director of Clinical Psychiatry with Small Pharma. But I think, for the purposes of transparency, it's really important to mention that on my first day in October 2020, we all realized that I couldn't have that joint role. So I couldn't be a director in a sponsor company for a clinical trial. And so because that would be introducing bias, and then of course I couldn't be doing the outcome measures for the trial. And so we did a lot to kind of really think about that. So for the whole time I've been working with Small Pharma, I've been behind what we call an ethical wall, which has meant that we've occasionally had contact with the research team in matters around the trial, but I've not had any kind of contact with the commercial side of the business, I think. And because of that also, that's meant that we've agreed for me to actually step outside of the company and become an independent contracted doctor, which is as far away from working for an organization than I've ever been, having been in the NHS and grown up in the NHS for such a long time as well. So that means I'm kind of in title and officially even more sort of independent from the trials as well. That does give me a little bit of extra time, which I hope to make as much music as I can and, spend more time with my family. But yeah, also in that time, I think working with Mind Foundation in Berlin, so to be distinguished from the Mind charity in the UK. They're an organization that are involved in psychedelic research in Berlin. They're very much a sort of an organization that's wanting to sort of train therapists in augmented psychotherapy. So essentially looking at psychedelics and ketamine treatments, but training up therapists for work in clinical trials and for work, above ground where these medicines are able to be used in an official way and when that happens. So that's in a mentoring capacity, which I've already started and is a really interesting process. I work with the Institute for Psychedelic Therapy, which is the organization that was created really by Tim Reed, who was our psychotherapy supervisor, and Maria Papaspirou, who I know from Brighton, and we worked together in Brighton integration circles, the psychedelic integration groups from 2019. So that's an organization which I'm an advisor for, and I kind of also do the academic circle, which is essentially like a journal club, critical appraisal, discussion around research as well. But what they've put together is a community, a real community of like-minded therapists and other affiliated healthcare practitioners who are interested in learning more about psychedelic-assisted psychotherapy. It's very much, for CPD, but they've also started a training program now as well, which it's kind of called depth relational process. And so it's very much a very sort of deep training program to help people really understand, psychedelic therapy in a very deep way. Obviously, that doesn't involve anything underground. It probably doesn't even need saying. It's kind of very much about kind of, helping people. I mean, holotropic breath work is a part of that as well, which is a very, very legal way of having psychedelic-like experiences in a very supported way. So, I think, working with Tim and Maria and Justine and Liz at the Institute of Psychedelic Therapy has been a real joy for the past couple of years.
And providing much needed training and education.
Absolutely, yeah. I mean, we started with talking about training for psychiatrists as well, and so that is for psychiatrists to sort of be a part of that and to learn as we all learn, through this process. So psychiatrists can be affiliate members, and psychotherapists with a private practice can be full members. But yeah, it's a great learning space.
And Graham, I just have one final question. Did you have a good mentor at any point in your career?
That is a great question. I've had loads of great mentors. I have to say, most of my academic training, I suppose, during my psychiatry training happened in either at St George's or South London and Maudsley Trusts. So all that was based in London. But the psychiatrists I worked with in Sussex Partnership NHS Trust have really helped shape the psychiatrist I am, I would say. And I think of a number of people, it's probably difficult to list them all, but, there's psychiatrists who have taught me about the importance of the patient's story, the patient's life story, people's life story and experiences. There's another psychiatrist who comes to my mind who was very, very much about psychopathology, phenomenology, sorry. So thinking very much instead of just symptoms, thinking about the person's direct experience of conditions like psychosis and schizophrenia or bipolar disorder. Such a caring psychiatrist, somebody who, had to work in the way psychiatrists have to work in modern mental health services, and using the Mental Health Act and all of that when really necessary, but cared so much about the patient journey and cared so much about his patients. So those are, two people that came to mind. And even the first person I worked with as well was, I remember so many of the things that he taught me in 2006, when I started in psychiatry, all idealistic and enthusiastic. There's so much wisdom in the psychiatrists I've worked with. So yeah, it's difficult to single out one person, but they're a great bunch.
It is so wonderful to have a great mentor or, a group of people that you can think of that have really helped you in the course of your career. I think it can't be underestimated.
Yeah, no, absolutely. And I think I will say that, I think Tim Reed fulfills some of that role as well.
Mm-hmm.
He'll hate saying this, but, I think, for thinking in a different way and, and bringing he certainly worked at the sharp end of modern psychiatric acute mental health care, whilst holding that awareness of psychotherapy, of psychodynamics, of all the other processes, the psychosocial processes that go on in all of us. So yeah, there's been a lot of people I've worked with who have been invaluable teachers.
I think that's a brilliant place to stop, Graham. Sadly, we have run out of time. This has been a great privilege for me talking to you, Graham. It's just been fantastic.
Oh,
I think the listeners, we've all learned a great deal. I hope you've enjoyed this as much as I have. And just for me to say thank you so much for joining us, Graham. It's been brilliant.
Thank you so much for inviting me. I can't believe the time has gone. What happened there?
I know. How did that happen? Thank you so much.
Thanks, Joe.